Referral management is important for this practice because we are perceived by the PCT to be a high referring practice.
The impact of using some of the productive tools has meant that we're asking questions not only of ourselves in the practice but also in our locality commissioning group. It gives us the confidence to reply, not that we're just a high referring practice, but why are we? So it's making us ask much wider questions of our own information. We looked at the process for the patient of that referral journey, both with my secretarial team and the clinical team. And we showed it as a storyboard in the staff areas of the surgery so that we saw it on a daily basis. So you could see at a glance the number of referrals that we did every month. It wasn't about quality patient care, it was about how we delivered that quality patient care. One thing I've seen that the productive tools have really helped with is with certain teams within the practice, and the secretaries have really got engaged and involved in that process.
Within my role as medical secretary, there's often issues that we find quite tricky within trying to do our job properly. For example, the dictation that the doctors provide us often isn't very clear. So as part of the Productive General Practice Referrals module, we were able to capture some data using data caption sheets about how we work. The data was displayed up in the corridor so that doctors could see where the time was being spent, and they could then see, for example, a lot of the time wasted was between us sending back the referrals back and forth between us and them. We came up with two main ideas. We have a dictation sheet which the GP uses to initially jot down who they're talking about on their tape, and we thought we would try and alter that dictation sheet to make it easier for the GP to specifically clarify which patient they're sending and where they want to send them. We came up with a laminated A5 sheet of paper which had bullet points of how we would like them to do the dictation.
The people nearest the service delivery are making the changes. Quality changes quickly, and the team are really getting some praise from the people they're serving, both patients and the professionals.
We've noticed in general that a lot more of the GPs are being quite a lot clearer, whereas a letter would take us sometimes a couple of days going back and forth checking the details. It can be done, typed and sent off within a day.
One of the things we did was to ask partners to assess their own referrals. We gave them some referrals that they had done about 6 months before, and then used a rating scale to decide whether the referral had been justified or necessary, or whether it could have been dealt with in some other way. And it was a surprise to me to discover that the number of referrals that people were sending was not particularly proportional to the number of patients they were seeing. Two doctors who do comparatively few sessions were sending the largest raw number of referrals, and this leads us into the whole area about what leads people to refer and not. Some partners were referring for procedures that could be done in-house, so we've had a process of trying to make everybody aware of what is available in-house, making all this information available and accessible on our intranet. I suppose the biggest initiative globally has simply been to raise partners' awareness of the issue of referral management and to make readily available the tools for them to do things differently.
So rather than being the highest referrer in our area now, we're not the highest referrer, which is great as long as it's matched with patients' need and quality.
It has certainly been very helpful for us. We wouldn't have got to where we are now without using that sort of approach.
New ideas, I think, is really good for the practice to help us move forward, because the NHS is ever changing, so I think we need to move with it.